Thank you so very much for joining us today, Dr. Acharya from JNU in Delhi. I really, really appreciate it. Today is August 31st, 2024, and the time is around 8:37 p.m. here in British Columbia, Canada. And we have received your consent form signed. Appreciate that. We have your consent to publish this interview online and also to use it as raw material and data for publishing a report, which we will share our findings with prior to publishing. Is that your understanding too?
Yeah,
okay.
I do agree with all of this.
Okay, thank you so very much. Okay, so we do have 6 questions, but before we go directly into those questions, Dr. Acharya, if you could be so kind to help our listeners learn a little bit about you, just some sort of a profile in terms of your positionality. Maybe you want to share your geographical origins, where you are now, a little bit of your professional journey, and as much or as little you would like to tell about yourself. That would be lovely.
Yeah. Thank you so much, Dr. Manu. This has been an interesting dialogue, which I think Juliana and you have initiated. And I was quite excited to get on to this conversation. Like you said, I am a social scientist trained in geography, my master's in geography, and geography being a fairly wide kind of subject, the discipline has a very wide scope. So I got the opportunity to zoom in into something which was more towards population sciences, which brought me to International Institute for Population Sciences in Mumbai to begin my career right in early 90s, in fact, 1990 to be precise, even before I had submitted my thesis, so that was very exciting. The idea was, even after submitting the thesis, I have to do the teaching. And if I'm getting an opportunity, might as well grab it. So while I was there, I did, that was my first position. So you can imagine that transition from studentship to teacher took me a while. But I learned a lot in that process. I started teaching courses on research methodology, population and development. And that's where perhaps I honed myself, or rather my interest, in terms of understanding what are the issues of health. And do we really think health is seen very objectively by those who are providing care at different levels versus those who are in need of the health care? So that perhaps was my zooming in point as I was preparing to do my lectures for research methodology and population and development course that I was teaching. And like I said, I was still in that transition from studentship to the teacher. I think that process of learning was predominant rather than, the role behind the table. So I spent about 9 years there, and then came the opportunity to join JNU in the Center of Social Medicine and Community Health. So at the moment, for almost a decade and a half now, that I've been working in the area of health and development to give it a larger perspective. But within that, I've been addressing issues of health equity. What are the issues of exclusion and discrimination in being able to access health, both in terms of care services, counseling, and what is happening within the system as well? So going by that, now my research interest largely rests in this area, and I've had a chance to get a couple of fellowships, which has taken me to countries like Botswana, like Philippines, like Canada, USA, and so on, not only for the purpose of research, wherein I've also kind of tried to zoom in into specific age groups. For example, adolescents and young people, when I was in Philippines, looking at what are the issues of discrimination or exclusion vis-a-vis access to healthcare services. And I've also, in that realm, had a chance to study 11 villages in Western India, coming from Rajasthan and Gujarat, wherein perhaps I try to investigate how women and children are in capacities to be able to access care. And I'm emphasizing on access versus utilization to make the point of difference between the two. Most of the time we see the literature talking about utilization, which very consistently talks about the state's perspective or the perspective of the provider. The service is there, you are there to utilize it. But then I think it's always important to see how the users see that service being available. But as a user, do I have the discretion to be able to use it? And I think that's why I pitch from the vantage point of access to be able to understand health. And so at the moment, I'm a professor at the Center of Social Medicine and Community Health, and I happen to be the chairperson to the moment. So that's where I am at present. So I have a couple of books to my credit, which ranges from workers in the informal sector and the issues of health among them, how Delhi, the highly urbanized metropolitan city, exudes the realms of discrimination and marginalization as an urban space vis-a-vis different sectors. Latest work that I have managed to kind of put together is mapping inequalities across the spaces that we have in India. There's another one in caste, COVID, and inequalities. And I think work on sanitation workers is something which is perhaps the latest in the line. 22, 23, 24, I think 23, 24 would be the last work. So here I am in terms of what I do and try to kind of argue for. Thanks, Manu, for giving me this chance.
Thank you, Dr. Acharya. It's our real big pleasure to have you here on this podcast. You've done so much. It's inspiring to hear you speak about the different projects, especially with such a strong equity lens and a deep understanding, to support community, especially women and children. Could you just tell me a little bit about your motivation in terms of how you personally connect to this? So what drew you into doing this before we get into question number 1? Can you just tell me about why is this so important to you to be involved with healthcare?
Sure. Thanks.
Yeah.
Manu, when I started working in the area of health and development, you tend to interact with both providers as doctors, nurses, grassroots level workers. Larger understanding has been that as doctors, we are providing care irrespective of your social identity. But when I actually was interacting with some of the cases, if I may use that word, and making observations, as a teacher, as part of the programs that we engage in, field work is one important constituent. And while we take the students in the field work, we visit different institutions who are providing care, who are working for policy making for health, etc. So a series of these observations over a period of time kind of intrigued me when you're seeing doctor-user interaction. There is a kind of differentiation which is visible in the sense which begins right from the appearance, if I may use that lens. How articulate you are when you're conversing with your care provider. What questions can you pose makes a lot of difference in terms of how the provider is interacting with you. So that, in fact, triggered to question this idea of, as care providers, we don't bother about X, Y, Z, and, the dispensation is similar. This is what triggered, and in fact, this is what induced this study that I've just talked about in terms of women and children to understand what were the issues. So, and the study, in fact, brings out very clearly that social identities of the providers and users intersect in terms of ensuring this kind of an interaction. We have a good number of studies which are suggesting that at the grassroots level, when we're talking about healthcare provisioning, there are demarcations in terms of how the ANMs and the ASHAs will probably spend minimum time in let's say, the locations which do not align with their own social identity, which could be on the basis of ethnicity, caste in our case, and also religion. Language, of course, makes an important intervention too, which is where, in fact, one of my students' thesis is based on this idea of how social identity could be impacting on the grassroots level workers' interactions with the care seekers. So this actually made me question, are we really all that generous about not letting these differences come in the way? So we do, I mean, there are efforts to minimize them for sure. But then after all, we are all human beings, and therefore there are evidences of these elements coming in. The other reason, which might be intriguing for you also, I come from a family of traditional birth attendants. Right. Of course, probably the traditional job has been given up for reasons I'm sure I can use in terms of, stigma and, how the caste-based identities put you at a different pedestal versus another. So while we've heard stories about how our ancestral women, and this is a work which largely women in the family would be doing. So I recall my grandmother's stories about how her mother and another lot would be probably going in. And something very interesting also, Manu, is that in that generation, that woman who was providing this care had a certain kind of esteem in the community, right? Which I feel has kind of disintegrated to levels, particularly when WHO said there has to be some kind of training. So the traditional was changed to trained birth attendant, etc., etc. And also superimposing that with the socio-cultural nuance, socio-identity related nuances, I think the dissipation has been happening on that. So coming from that vantage point, I thought it was also important for me to see how, if I may use my own reflexivities and then see, does it really work the way it is? Because the same act, when a gynecologist is doing, it's seen differently. When a traditional birth attendant is doing, a lot of that imaging of the erstwhile social stereotypical nuances are there. So I would probably want to believe that that's yet another trigger over and above what the literature has been suggesting. So maybe I would really want to. And then subsequently, as I grew in my discipline, in my understanding of the questions I was trying to raise, I've had some very good set of teachers also who kind of honed me in terms of looking at these realms of, if I may say, the subtle lens, subtle discrimination which was existing, and most of the time we were trying to not look at it. So the idea which kind of came to me, if I don't look at it, I will not recognize it. And if I don't recognize it, I will not be able to address it either. So some of these elements were important for me to take on board.
Okay. That's wonderful. Thank you so very much. That really does help sort of contextualize what brings you into this work. So you have this personal connection and also your own inquiries based on your lived experiences. And now as you go forward in your work, you realize the importance of really acknowledging what you have seen and what you have felt in this very real way through your study. So thank you for that. Now we will shift right into the actual questions, if you're okay. So question number 1, how do you understand social justice in your particular discipline as a senior faculty member?
Manu, I'm sure I don't have to dwell more on social justice. You're fairly much familiar with the whole idea of social justice being something that we need to be fair in any kind of treatment, any kind of opportunities that can be available to all individuals with equity as a core. And even in the theoretical sense, I'm sure we do try to understand and also perhaps equate it to the very idea of justice for that matter. And then when we put the two terminologies together, people on one hand and equitable access to various kind of resources on the other hand, I think together puts it for us to understand. And a whole lot of literature which has got itself in place right from if we're looking at the recent literature from Martha Nussbaum, initiating the dialogue in the recent years, if I may say so, vis-a-vis, all other philosophical roles theory itself. So we do have a lot of realms coming in together to talk about how we see social justice in the larger context before I start kind of connecting it with my area of work. I think it is also important to therefore connect all these elements when philosophers have been explaining social justice in terms of liberty, social, political, civil, etc., etc. How do we really bring that into execution? And that's where perhaps in the realms wherein we place, maybe take a call on the historical literature also, right from John Stuart Mill's work, wherein you locate the economic parity also as an important relevance over and above the civil and the social context of equality or equity that I may probably bring in. So I think by the time we reach the 19th century, through the work of John Stuart Mill and Henry Sedgwick, I mean, I think we can bring in Henry Sedgwick as well, economic inequalities also become relevant in understanding social justice. So when we bring all of these elements, to me, I think there's an automatic connect to the area of health and development, and I'm going to expand on that fairly much. When to my mind, when Rawls talks about social justice, he is also negating some of the historical context by way of which I think the realms of economic parity in consonance with the social construction of these disparities or these inequalities become very, very important. And I think it's then that we start recalling in terms of rights become important. To be able to access an opportunity, to be able to access a service, if my right to that service or that opportunity is not defined or not explained in whichever form, it becomes difficult for me as an individual or as a group to be able to access this. And therefore, perhaps to my mind, the notion of social justice has been different in different cultures. So when I probably relate it with the idea or the framework within which health is located by way of health system, health services, health care, the nuance of prioritizing whose health and when comes in the same way as development for whom and why. Development for one could not really be the development for the other one. So I think this multifaceted nuance of social justice brings in too many explanations for it. And I'll try to zero in to the idea of health, and largely because that's my area I work in. That also perhaps then makes me think about how do, when I'm talking about the larger context of this access to resources. So health and well-being in today's context is perhaps the main crux on which the people per se, the core of the human being, the core of the development is being put across. If you're healthy enough, development falls in place by way of different roles that one has to play in the process of development. And therefore, I think it becomes very important to be able to have equitable access. Now, if I have to play a role in development, I must be employable. And to be employable, I must have access to education and my schooling. So that's where perhaps we come to this inequitable access. And any outcome data that we can lay our hands on in terms of employment, in terms of education, in terms of health outcomes, there is a disparity that we see across social groups, right? And that axis of social group could be religion, caste, ethnicity, economic parity, etc., etc. We see a very neat distinction of, if I divide the population in the two broad categories as privileged versus underprivileged, or any two broad categories of haves and have-nots, if I may use the cliched terminology. We see that those who are privileged have a better outcome, any indicator that we might want to take, despite the fact that we've infused fairly much in different kinds of programs. So interestingly, we do see an upward trend. Literacy, for example, if I go back to the census data itself, from 51 to the last census that we have at our disposal, there is an upward trend across social groups that we see. But what perhaps is interesting for us to note, that the gap between different social groups, right, the SC, ST, OBC, general, the broad administrative categories that we might want to bring in, that gap is almost consistent throughout that period of time. So that probably instills that question that we do probably need to relook at the policies. The policies have been there in place for a while, yet the gap has not been minimized, which is where perhaps the affirmative action context becomes important in ensuring this trajectory that I'm trying to bring in terms of employability versus education versus therefore health. And health, when I say, it doesn't really restrict itself to physical health. A lot of mental health issues also get incorporated. If I remain unemployed for a long period of time, it is going to impact my mental health too. If I don't earn enough, for example, it's going to impact my health. And we know there are a lot of people which are, in fact, if we go by the economy of the country itself, we have a larger share in the informal sector as compared to the formal sector. And within informal sector, you have more women who are there as workers as compared to men. So with all these disparities visible in our context, over the period of time, through recommendations of different committees and the constitution itself being one, that we today have Ministry of Social Justice and Empowerment, which is taking care of these disparities, and we have a whole lot of programs which are put in place, a whole lot of schemes which are there in place vis-a-vis addressing these disparities across different groups. But like I said, despite all of this, we do have those gaps existing, and we ought to be kind of taking a call on this. Now, this is somewhere I might want to invoke Dr. Ambedkar. We might be familiar with his idea of social justice, and I think the whole nuance of the Constitution, the construction, if I may use that word, of Constitution over these years that the makers of the Constitution took. The realm of social justice was what was at the back of it, the liberty, the fraternity, which of course was his understanding by way of his interaction with Rousseau's work and the French Revolution. Right. So when we start connoting the idea of social justice in our context, we can't not talk about this element of the Constitution itself, which then also draws me to the idea of why did Ambedkar want to bring in the notion of social justice? And I'm sure, as we know, that he himself hailed from a marginalized community, perhaps having experienced the disparities, the discrimination. He felt that human beings ought to be treated equitably, equal. And if I may bring in the realm of religiosity over here, the element of social justice, if we look at in context of the Hindu philosophy, religion per se, right? In the form as it has all mostly dispensed across board in its different forms. The ancient Indian approach to justice was largely in terms of, if I may say, it had that element of performance of duty on one hand, with the notion of rights, that perhaps evolved the four varnas. There are some of us who have the right to perform the duty, and there are some of us who have the rights to experience the benefits of those services. Now, and therefore, I think there were two approaches that literature throws up for us: the Dand Niti and the Dharma. Right. So, and it it very quickly, I mean, it really gives us that concern of social justice, which ordains these four varnas in different kind of work that they would therefore be assigned by way of the, if we say how the system per se, the dharma itself is offering you to take on. So as if we say Hindu dharma, and I think there is a different connotation when we use this phrase versus Hinduism or religiosity, for that matter. There was there was a system in place which was actually relating itself to the ancient legal systems, legal frameworks, which were connoting that this needs to be, this is the ordain, so it can't be changed for that matter. And I think that ordain was what Ambedkar was questioning. You can't really not see the equality across human beings, right? You can't be treating one different than the other. And I think therefore, we have literature questioning these kind of disparities across. I mean, I'm contextualizing vis-a-vis our, and therefore I'm referring to this, but this is evident even across different geographical spaces, if we want to kind of bring in over. So I think that is precisely why we have the liberal approach to social justice coming down to the Marxian approach, which really puts the realms of social and economic parities, which become something like a core of social justice. So I think I am trying to invoke Ambedkar in context of health and social justice also because most of the time we have recognized him, understood him as stereotypically the messiah of the downtrodden, overlooking his own scholarship in terms of the disciplines of economy, economics, political science, social sciences. His approach to the very idea of social justice, therefore, reflects upon how he nuanced the need for healthcare per se. And I would want to probably make you rethink about the much talked about Mahar Tank episode, the satyagraha, which was led by him by way of being able to access drinking water. Right, the Mahar tank, movement is how we usually relate or label it as. Now, normally it is seen as a movement for vis-a-vis the social identity, right? But I want to add a dimension to it. Social identity for sure, because these were people who didn't have access to that water body, right? But then the question is, why water body? Because water is intrinsic to human beings, to human life, nurturing the human life, and therefore the call to be able to access the water body, which is enabling a vital source of life, water, that is. So that context of recognizing the importance of water for those who did not have access in a very specific form, to me becomes something which is relevant to his interest, his farsightedness, and his vision vis-a-vis health. So, in fact, if I may go back and quote what one of the former Chief Justices of India, P.G. Gajendra Gadkar, when he was referring to this whole business of constitution vis-a-vis, how it shaped up, etc., etc., he says very categorically that Ambedkar is a modern Manu. I'm sure it might not go very well with some of us, but the contention he was trying to make, that unlike Manu, he recognized the equality across human beings. So I thought that was something to bring in over here in terms of putting us all together by way of the argument I'm trying to make. And then his interest in women's health particularly comes up very clearly when he is way back in 1938 talking about the physical conditions of children who are born, and he's trying to address the realms of disability, and therefore giving birth to a disabled child versus the nuance of medical termination of pregnancy, which became contentious also. So the point I'm therefore trying to make is that in those years when it probably would have been very difficult to think about these things, he was there looking forward in terms of the health of the mother and the child, that medical termination is fine, unlike in today's parlance or in the parlance of the subsequent years, where all of this was more for population control rather than the health of the women and children. So, and also perhaps the subsequent, if I may also talk about the Mica mine bills, etc., that also gave a lot of respite to women workers who had to go in the trenches for work, etc., etc. Maternity benefits, 7 days week, 6 days week, number of hours of work, etc. So all that comes in. So when we relate all of this to the idea of health, I think health on one hand is an attribute which ranges from an individual to the larger system in which and through which I can be healthy, I can take care of my well-being. So the concept of health, which is individual, has to be seen in the light of the larger framework of public health, which is where you built in your systems, which is where you built in your infrastructure, your personnel who would be providing care. Now, in all this backdrop, if we are understanding that there are social differences, there are inequalities amongst us as individual living beings, there is a chance that our behavioral dimensions will also be infused in the kind of services we are providing. Right? So, like the point I was trying to make, however much I might say as a doctor, I don't discriminate, there are chances that I will end up doing that by way of, and it might be so much internalized that I may not be realizing also that I haven't spent enough time with X versus Y. So I think addressing this inequality in access to health becomes very important. And this health, the notion of health, has to be disaggregated in terms of care, in terms of counseling, in terms of provisioning of services, right? Counseling in the sense, do I really need this or I don't need it? Over medication, for example, who is there to inform me about the level at which I need to do that? Is the grassroots level worker visiting me to inform me about it? And this whole idea of social justice, therefore, brings in the larger realm of prioritizing the vulnerable populations wherein the access is limited. And therefore, I think a lot of thrust is given on the grassroots level workers, wherein the expectation is that they will go to the marginalized groups and marginalized on any axis for that matter, particularly social marginalization, given the understanding that the educational levels could be lowered and therefore information, etc., etc. So that's something which perhaps brings me to the fold of this social justice within what I would say as public health. And that therefore brings me to talk about social determinants of health. And this perhaps becomes very important for those of us who are approaching health from social science perspective. And perhaps that's the distinction I'm also trying to make. Health has to be brought out of the biomedical regime and seen in the framework of biosocial dimensions. In fact, at the moment, it's biopsychosocial and ecological perspectives being superimposed in that. We can't really leave on any, because it's such an intersecting dimension. Health can be influenced not only by my economic considerations, but my housing, by, like I said, my employability, my incomes, etc. I mean, a whole lot of those multi-dimensional aspects come in on one hand, and on the other hand, how the system is creating that enabling environment by way of which I can make those accesses. So a lot of literature in recent times, if we go by social determinants of health, especially in South Asian context, has started talking about both religion as well as caste, in addition to ethnicity, as an important determinants of health, right? And that also perhaps leads us to the dimensions to bring out health from the realm of health inequality to
Right.
the realm of health equity. And that's the moment equity comes in, I'm sure human rights come in, because reproductive rights, for example, you can't be just pushing in the contraceptives into my body until and unless you inform me, or anything for that matter. Like I said, over medicalization and the malpractices which are related with over medicalization, pharmaceutical industries shoving down the drugs onto the users. So some of those things become very, very important. And perhaps one more element that I might want to bring in here is the idea of participation, for example, and it comes right from the community participation realm. As a group who's seeking care, as an individual who's seeking care, do I have that parity to be able to take part in my medication, for that matter? Am I informed enough? Are there machineries to inform me about what is good for me and what's not so good for me? So some of these elements, I think, become very, very important in research. And again, I would probably want to reiterate in all of this, perhaps, another important element by way of human rights perhaps becomes important is the very ethics as a constituent of health research, for example, and dispensation of health. And in dispensation of health, like I just said, what are the practices, for example? What are the interactions which are happening between the provider and the care user? Am I being given the same kind of information, same kind of parity by way of others, versus how the dispensation could be in terms of research? Ethics in research is a big thing to be
Right.
adhered to, especially human health that we are dealing with. Am I informed about the drug which is being given to me? Am I informed about, like you did, particularly, am I willing to be a part of this study? And all right, if it is being published, etc. So I think they are in some way protecting me in many ways, by way of in this case, not being misguided by way of what is useful for me or not useful for me. And that's where perhaps the relevance of the grassroots level workers becomes very, very important, if I
Okay.
may say
All
so.
right. So, Dr. Acharya, when I listen to you, I hear that as you describe your understanding of social justice, it has grown from reaching out and drawing on Western and Eastern scholars in the field. I hear that you also are drawing upon your experiences in the field as you see interactions between those who access healthcare and those who are providing it. And I see that correct me if I'm mistaken, but it sounds as though your understanding of social justice has really quite deepened as you have had more time to, take your field experiences that are local and also international into consideration alongside the different conceptual literature that you've had a chance to read and interact and engage with and think so deeply about. Do I have that right?
I completely agree with you. Yep. Yeah,
Okay,
it has shaped my understanding alongside. Yes.
definitely. And do you think that you've shifted very much? So in Canada, we have a difference in terms of when faculty members begin, before they receive their tenure, which finalizes them before they go higher up, like you are as a chair and you've established yourself for multiple years. Are
Mhm.
there any differences in terms of the freedoms you have to speak about social justice in your particular practice? Do you feel like you're more liberated to speak as now you're a senior faculty member, or is this something that has not crossed your mind? You've always been able to say what you wanted to say as a scholar in India who is doing this great work within healthcare?
Yeah. Thanks for posing this question. Like I said, most of the time, health research emanates, and especially public health, has a dominance of medical fraternity as compared to the social sciences, although we try to say that there's a parity across, which is probably what is required, and we believe. by way of this parity, it's not in any which way undermining the realm of medical sciences. Of course, it is important. But then to be able to also adhere to the idea that it's not only the physiological conditions that create that illness, right? Poverty, for example, the realms of discrimination create a lot of psychosomatic disorders for that matter. So when you pose this question to me, one good thing is, thanks to the Constitution and the toil, and I would again go back to Dr. Ambedkar's contribution, that we do have policies in place. The whole Ministry of Social Justice and Empowerment is there. And like I said, a whole lot of programs are there, from rural development to Manrega for individual work, to housing, to scholarships, and even employment. The whole idea of reservation, for that matter, has some element of bringing in that parity, which we assume and believe has not been there for all these decades. And like I said, despite all of this, things haven't become the way they should have been. So there is parallel kind of move when you look at literature, when you interact in the discourse. There is a voice which is kind of agreeing to this gap which is persisting. And there is a voice which does not agree with this gap, with the existence of this gap, for the simple reason, arguments being that there's been enough time which has been given for these gaps to be filled. And yes, the gaps are minimizing. It will take time, etc., etc. Why should the younger generation be penalized for the older generation, etc., etc.? All of this is there. And like I said, there are two parallel voices happening. So while the state has put things in place and things haven't shaped up the way they were expected to because of affirmative action, when countries like Japan can do away with the plans of their affirmative action in a shorter duration of time, we have had for a longer period of time, we haven't yet managed to reach there. So there is a likelihood that we will probably need to revisit the affirmative action by way of group-specific policies, and then perhaps ensure that it continues on for a while till that parity is coming. The misconception is that it should not really be for eternity. Yes. Bring the parity, and I'm sure nobody will want to continue with it. Nobody wants to be stigmatized. Nobody wants to remain downtrodden, quote unquote. So bring in that parity, and I'm sure nobody will want to be labeled as somebody who is discriminated, somebody who is at a lower parities, etc., etc. But till that parity is brought in, I think we have to be open to the need for those processes through which we can bring in the parity, and affirmative action being one of them, which I again reiterate needs to be revisited for various kind of reasons.
Absolutely. All right. Dr. Acharya, you actually have started addressing question 2 and 3 as well. So if, with your permission, I'm going to move to question 2.
Sure.
And I'm just mindful of your time as well. So question number 2, because we have 6 questions. Question number 2 is, what, if any, are the social justice issues you have encountered in your area of expertise? And I've heard you speak in question 1 about the following. You've spoken about an unconscious bias towards care, counseling concerns, the provisioning of services as another area, and the process of the actual person who's receiving the care to partake in the decision making. So these all seem to be areas within the healthcare that you have highlighted as social justice issues. Also, a really big one, you have also spoken a lot about social determinants of health that nicely, have an interdependent relationship often with marginalized communities within India. So it seems like you've named a few of the social justice issues that are already very present in healthcare. Are those the ones that you would identify? Did I do a good job summarizing the main issues?
I would probably say yes to it, because if we really want to address the question of health, and maybe in the larger frame of public health, and that's my area of work, this interaction between provider and the user is being governed by these elements. And therefore, I think this needs to be addressed because it is impacting on utilization from the provider's side and access from the user's side. So I completely would want to endorse that these are the points that I'm trying to make here. In addition to this, perhaps, which maybe I have not inflated further to it, but when I'm saying that this interaction between the provider and the user, I think the empathy of the provider becomes very, very important. So as a grassroots level worker, and if I fall back on my study, it comes out very clearly that this kind of interactions which are reflecting on discriminatory behavior are more evident at the grassroots level workers as compared to the higher order providers. So my understanding would therefore be that if there can be some sensitization of the grassroots level workers, some kind of, maybe not only for the grassroots level workers, but also for the community, to be able to overcome these biases, these stereotypes of, and I completely understand the workload of the grassroots level workers. I completely understand that because most of the time, if you look at the geography of a given slum or a village, most of the marginalized groups reside on one end of these entities, right? So as a grassroots level provider, when I don't really have much services to help me do my job, to go to a household which is at the far end of the village probably is a deterrent. So I try to meet my targets, however much we might say we don't have targets. We might want to still meet by way of being closer to the thing. So I think that kind of sensitization becomes very, very important at this point. And also moving across from one end of the village to the other end, and I'm saying this based on my study, which is very interesting for you to probably take note of, Manu. While I was doing the field work, I had these young kids following me, like it happens usually in the village when you're there as a researcher. They see you new, they want to, get into conversation with you. This is the young kids, who probably joined me because the school had gotten over. So they come along, I make a conversation, they're walking with me, and we now crossing to the other side of the village. Some of them continued to walk with me, others did not. So I looked back and asked them to come. And they jittered and jibed and they smiled and they didn't come. And then I got to figure out that that side of the road was where the Dalits resided, and these were the kids who were non-Dalits, and they were not probably allowed to go to this side. So all this while they come out of the school, they're happy. But then there are certain do's and don'ts which are very, very neatly carved out on their head. And this is not very far away from the time today, sometime during 2006-07. So, I mean, of course, 10-15 years ago, but then it's not all that far away a time also. So I think these I would go by the pointers which you have reflected in terms of what I would probably want to emphasize on.
All right. And you're very good at this, Dr. Acharya. I don't know how you do it, but you already lead into the next question. So it's very good for question 3. Number 3 is, what are some social justice initiatives that are occurring in your discipline to help build awareness and or address social justice issues? And when I was listening to your answer to question 2, I heard that you're talking about we need to pay attention to policy, maybe think about affirmative action policy again. I heard you thinking about getting people who provide services at grassroots and higher to be more sensitized to the cultural needs and the social determinants and the roles that they play in providing service. And I also heard you talk a little bit about having an understanding of what it means to be utilizing a principle of ethics in healthcare in order to address some of these issues of social justice. Do you care to elaborate on any of that, or am I very far off in terms of how you feel there are some social justice initiatives that are helping to build awareness and address the social justice issues that you said?
Yeah. Uh, Thanks for bringing that on board. I think I might want to elaborate on some of these programs which are in place at the moment and have addressed, some of these issues of social justice. To begin with, the very recent post, rather not so old either, Ayushman Bharat, for example, right? That's perhaps one of the largest program which has been targeted as health provisioning, health insurance to be precise, for provisioning of the care, and it is targeting the vulnerable population, right? And vulnerable largely in terms of the economic indicator of being below the poverty line, kind of a thing. There is the provision under this program, which is now which is labeled as mission, is that uh, if I need care, there will be care provisioning happening to me up to a certain level of expenditure, which is, I think, which as of now stands at 5 lakhs, if I recall my literature correctly. What is important, perhaps, is that this was an outcome of what the health policy of 2017, that's the latest policy that we have, uh, the recommendation of the policy, which was in consonance with the sustainable development goals, that we have to leave no one behind, and therefore the most vulnerable, addressing the needs of the most vulnerable, was one of these ways through which one could address the needs. And if we go by what the ministry is informing us, the coverage seems to be very, very exciting, and hopefully the care is being provided. But like any program for that matter, there are loopholes and there are lacunae. So we do have people and literature also suggesting that probably these are the gaps in the program, and this is how they can be kind of plugged. What is also interestingly, which has happened under this program, is largely the first contact of the people and the health system, which is the primary level, primary health center or the sub center. A lot of sub centers, which is at the village level, have been converted into what was labeled as health and wellness centers, and they have a local name which has been given to them as Ayushman Arogya Mandir. That's the label that they've been given at the moment. Again, an effort to be able to reach to the lowest level of people, where they can make use of these care provisioning. The questions of specialists being present, the question of services being provided over there can probably remain as much as they're there. But the fact that it is a good beginning, and I'm sure as we enhance that, things could fall in place also. And similarly, I think the conventional Ayushman Bharat also therefore has a subset, which is the Pradhan Mantri Jan Arogya Yojana. We have these as part of the Jan Arogya Yojana, we have these centers which are giving you generic medicines, Jan Aushadhi. That's Jan Aushadhi. That's the terminology that is being used, wherein again the branding of the medicine incurs certain cost. So these are the centers which will probably giving you medicine at cheaper cost as compared to the branded medicine where the cost is much more. So I think, to me, as of now, I would consider this effort as an important effort to be able to ensure within the system how the care provisioning can reach to the most vulnerable population. Similarly, like I said, there are efforts for housing also, both in the slum areas within the urban spaces and also in the rural areas under various housing schemes, which probably is initiated as Indira Gandhi Awas Yojana. We have now, the nomenclatures have changed, but the idea remains the same, that the vulnerables should be provided with employment.
Mhm.
while the Mahatma Gandhi National Rural Employment Guarantee Scheme does talk about the employment, but I'm sure we still need to do a lot for a regular kind of employment rather than a 100-day assurance that is given for earning the livelihood. Nevertheless, like I said, there are some positive outcomes which are visible, and what is needed is that uh, we are able to inflate it, enhance it in certain ways. I hope this answers your question.
Yes, yes. So I'm intrigued to know. So in particular initiatives for, healthcare services to provide to those who don't have so much access, there has
Mhm,
been a India-wide, I'm
mhm.
talking, it's an India-wide policy for helping with health insurance for
Mhm.
all people, regardless of their caste,
Yeah.
regardless of their ethnicity, regardless of their religion,
Yes.
for 5 lakhs covered. And then there's the same thing with the health and wellness centers you spoke about. This is also at a federal level,
Mhm,
like the national level. Okay,
mhm.
so just a quick follow-up question. What does 5 lakhs get you as a marginalized person who might have routine medical, costs? Like, will
Mhm.
that cover, like, what, for our listeners who are not familiar with the currency in India,
Yeah.
can you explain how far that money will go, how supportive it would be, and
Sure.
perhaps also elaborate on your health and wellness centers in terms of those who are experiencing, hardships of more terminal diseases like
Mhm.
cancers that don't have,
Sure.
you
Sure.
know, um,
Mhm.
medicine readily available. So
Yes,
if you could
absolutely.
speak to that, I just want to know because we spoke so much at the very beginning about access, right? Instead of
Yes,
utilization.
yes,
So I'm just
yes.
wondering how you can take those two concepts that you so particularly wonderfully articulated, and bring them into these two initiatives and tell me
Sure,
how you see that
sure.
works, or any limitations maybe, or what your thoughts are on that, if you may, please.
Yes. Thanks, Manu. I think this is a very good vantage point to kind of revisit the programs which usually the states put for us. Uh, while it's a very good idea to read 5 lakhs, up to 5 lakhs that is at my disposal, which I may be able to use for my illness if at all it comes to me. Um, it may be fine if I am with an illness which isn't all that bad. Even the bad C word, if it is of a moderate kind, I may be able to deal with it. But then in cases where the malignancy could be of higher orders and this amount is really not enough, one chemo session perhaps will cost me 500,000 in a private hospital. In public sector, and that helps me bringing in the divide between the public and the private, the queues are so long that perhaps I may not be able to use these services. And therefore, this element of equity and the difference across the public and the private sector becomes very important to take a call when we are looking at these programs. While 5 lakh is fairly good in terms of being able to, ensure an assumption being that not all of us will get the illnesses of the kinds which will require more than this amount of money. But then there are evidences which have reported that claiming the money which I have already spent is a mighty issue. Right. And that's why I was saying that while on one hand we do have these programs, there's still which needs to be taken care of. And let me therefore also bring in this realm of the public and the private sector. Uh, the we market, and I say this consciously, has functioned to bring in the private sector superimposed on the public sector by way of denouncing what is available in public sector is not up to the mark, is not good. You have to wait for a very long time, etc., etc. Therefore, come to private sector, and we are there to provide you everything. Although there are evidences in literature from personal experiences across board, which are suggestive of the fact that the good amount of money which you spend in public sector does not ensure the best kind of care that you may be given. Therefore, I think the subsidies which the private sector has been given by the state, which is something to the tune of 1 rupee per square feet of land. The cost of the land for the private sector is 1 rupee per square feet of land. And this is by the Qureshi Committee report. You can access the report online and take a call on it. To get into the public-private partnership, to be able to widen the coverage which is required under the universal health coverage, etc., so that public sector is not able to reach, therefore private sector should come and fill in that gap. Now, when we do this with assurance that private sector is going to allocate 10% of its beds for EWS, economically weaker sections, etc., etc., it does not really actualizes. And I'll give you a reason for it. Not really anecdotal, but coming out of some of the research that we've been doing. If I'm not informed about this policy that private sector gives me this access, I will not be able to use it. I'm not literate enough to know about it. And even if I'm literate enough, I am not educated and aware of this provisioning happening over there. And if I happen to know all of this and reach the facility, I'm not too sure how empathetic will be the providers with me, given my appearance of an illiterate daily wage earner. Right. So some of those elements have to be addressed when I say, that sensitization of the providers needs to be taken care of. And now most of the private sector care are functioning as an industry. They are no more in the fold of what welfare regimes see as health. Health is no more a public good. It's become a commodity. And therefore, profit is where we rest in terms of giving that public private care. And in that light, to my mind, when something like the Ayushman Bharat arrives, it is a respite. But the respite has these loopholes which need to be taken care of, addressed. So that's where perhaps I will want to stop in here. Health and wellness centers also, perhaps it's a similar kind of a thing. It's very interesting, Manu. Last year we were with students on the field and we happened to visit some of the health and wellness centers. That was also the time when most of these centers were being converted into health and wellness centers. So a lot of them were painted very fresh. They had machines and gadgets still wrapped in the corners, yet to become functional and all. And maybe there's a need to do a subsequent visit to see them functional. So again, the realm of dissemination of information, creating that awareness among the people that you should be using it becomes very important. Right. In addition to dispelling that it's not really the private sector which will give you the best services, it's the private sector which is where you still go for your chronic illnesses. I mean, we all flock to All India Institute of Medical Sciences for meaningful, consultation, et cetera, for long-term chronic ailments. So if that is still there and subsidies which are being given to the private sector can be diverted in a way, retained in the public sector, I'm sure the similar kind of service provisioning can happen even in the public sector. So the mindset, the way market has functioned, to change that mindset in favor of private sector is what perhaps we need to also address, therefore.
I think that's your primary focus, to be honest. It sounds like India's healthcare system, based on what you've just commented, is becoming hyper privatized. You're having an issue around neoliberalism. There is industry and profit over healthcare and access to it. And that's huge. This is the main structural inequity in your healthcare system.
Absolutely.
And
You know
until
what?
that is addressed, Dr. Acharya, I don't think all the other pieces can
Sure
even
enough.
begin to be addressed, right? So
Sure enough.
if the
Sure enough.
government is trying to support, it almost seems like, with all due respect, it seems like there are some policies or initiatives being created that are actually quite empty in terms of actual usage. So if you want to use the public system and it's over long in terms of waitlisting and access, and there is this deficit attitude towards the care that's being provided through the public system, it's almost for your common person in India, it doesn't seem worth the effort. And it just puts people off, and therefore they never get the health care. And if in the private sector, which is heavily supported by the government, given your 1 rupee per square feet of land, which is very enticing, if that is more seen to be the main way to go, but they don't know how to welcome or culturally be responsive or ethnically be responsive to those who are seeking care, who figure out somehow through a loophole that they actually have a right to get some access to healthcare, even in the private organizations that serve, you know, all of the medical needs that they might have. It's very disheartening to see that basically through my little chart of notes here that I've made, that the public system and the private system will not meet the needs and does not acknowledge necessarily the identities of these very marginalized and vulnerable people. So they're kind of left stranded. And until financially this has been redistributed properly on an organizational level, on a structural level, for the very, architecture of medical organizations in India, I don't think anything that comes out of it will support the marginalized people. It seems like this is a really big problem. If I'm listening,
Yeah.
do I have that right?
Yeah, you are almost right. I want to bring
Okay.
in one element, maybe in terms of a bit of expansion. When we look at these schemes, and Ayushman Bharat, like I said, is one of the biggest schemes globally, with a very good intent, right? But when it is getting translated, and if you translate 5 lakhs into your Canadian dollars, you know where it stands, right? And given the expenditure which I would incur in private sector versus the long queue that is there in the public sector, it really doesn't leave me with much. There is a support for sure. And in this support, there is some kind of maybe a consolation that I have. If I fall ill, yes, this is there with me. But then the structural realms of being able to retrieve this money for my use is yet another question. And we haven't really got into that in great details. But therefore, I think I would still want to reiterate that the system which has been put in place with a good intent need to be executed also in the same good intent. Otherwise, uh, if we put healthcare in the hands of the market, market will always care about its profit, and therefore whether and to be able to ensure profit, market will generate that kind of hypes that I'm the best, right, irrespective of. So I think what I'm trying to therefore also say, the kind of subsidies which have been diverted to the private sector, if there is some kind of sharing of those profits by way of retaining them in the public sector itself, I am sure that the facilities will be good enough to be able to adhere to these long queues, which are the deterrent at the moment. So going by that, the public sector, if is strengthened, will ensure that more of us can access those care which become out of our reach when they are in the private sector, right? So it's almost like in a common parlance, you can't afford to fall ill. You can afford to die, but you can't afford to fall ill. So that's that. And that certainly doesn't say that public sector is not moved ahead. It has moved ahead, but this dichotomy in terms of public private partnership has actually tilted in favor of the private, which is more for the industry rather than for the people. That's what I would, and this actually emanates from our own health sector reforms way back in the 90s that we adhered to, right? I mean, very simple. Just another example, if I may bring in, Arogya Shri, erstwhile program which was there for maternal and child health care and the deliveries. The fact that this program had been put in place, we see a spurt in cesarean section birth deliveries, because there was this program which was inducing some kind of institutional care at birth. And that institutional care was available in X kind of hospitals, wherein the tripartite association of the user, of the insurance provider, and the care provider will ensure this kind of transaction which will be happening. So also therefore the over medicalization. Did we really need a C-section? But if I underwent the C-section, I will get this amount of money, which I don't exactly remember what the amount was at that point of time, will come to my kitty as the care provider, and perhaps also as a mother to take care of my birthing and the ANC to PNC kind of a scenario. So I would just probably want to add in a couple of those things to it. Mm-hmm.
So Dr. Acharya, I think, yeah, you've said it very clearly that it is about the intention and how it's actually activated. So that's very important because, in today's day and age, a lot of people have multiple good intentions, but they're not actionable. So it makes one question at the end of the day, if the action isn't actually there, did the intention really matter? Anyhow, let's move to question number 4, which is how do you respond to microaggressions or forms of discrimination, if any, that you personally, Dr. Acharya, have experienced?
Okay.
So I don't know if they call microaggressions the same things as discrimination in India, but a microaggression here in the Canadian context is more about when people have more of a passive aggressive behavior towards you. So if you go back to, how you were talking about when people are accessing healthcare as users, how they present themselves, what they look like, and how that's being responded to. So in Canada, if let's say you are a racialized person, a brown person, a Black person, an Indigenous person, there would be some level of discrimination in terms of how you would be treated, unfortunately, and it wouldn't be so direct that somebody would say, well, what are you doing here? It'd be more of how they treat you in their behavior. And that in the Canadian context, we really have now moved from discrimination to microaggressions because they're very difficult to identify. So I don't know if that helps at all, but I would love to know if you've had any experiences of this.
It does, Manu. It really, it's absolutely in the same line that how you, understand microaggression. And I can have a number of examples to reflect on microaggression, which could be based on various kinds of social identities, right? Say, for example, let me begin with yet another composition in this whole business that we've been talking about vis-a-vis health, the language. And by language, I mean your capability of being able to converse, for example, in English, right? And that itself can be something which can put you in a disparate position as compared to somebody else. I can speak fluently, so I'll be considered as the best, perhaps. And if I don't speak fluently, I'm nobody. And I'm drawing this example from the classroom, right? Wherein in the Indian education system, I'm not too sure how much of it you've had a chance to be a part of, none. So let me just share this with you. Much of the learning that we are doing till class 12 is like learning, mugging up what's there in our school textbooks, right? Julia is kind of nodding in agreement. And then we are reproducing that in the examinations. The ma'am has told me answer number 2 is from this line to this line on this page. I have to mug it up and reproduce. And we do this till our class 12. And if we don't get 99%, we are dead. Okay, in today's parlance, right? Unlike our generation, when 60% was a great achievement, right? 75% was distinction, etc., etc. Today, if it is less than 99, neither the parents nor the teacher nor the school is happy with you, so you are a gone case. Now, this kind of exertion that we are putting in on the school kids in itself has a lot of psychosocial realms over and above the physiological conditions that keeping up late at night, studying for the exam, going for the coaching centers, etc., brings in. Now, all this is happening in a backdrop where I'm mugging it up alongside my vernacular background versus my public school background. And public school here means that you're speaking in English, your medium of instruction is in English, right? So you're likely to pick up English as a spoken language much better than when I am in a vernacular situation. Now, with this kind of background, I come to a college and I'm expected to do original thinking, original writing, critical thinking, etc., etc. Come to the university without being addressed this at the college level. In the university, you're supposed to do research, do original research, etc., etc. Where is my language helping me? And where is that bridge at any level that is enabling me to develop this skill? Right? So interestingly, Manu, University Grants Commission, the body which is as of now kind of governing the universities here, stipulated that there should be certain remedial classes to hone my English skills, right? So today, if I relate from my own university, we have a linguistic empowerment cell, and I understand there are other universities too which have similar kind of, for example, Vrije University in Amsterdam has a MOOC cell which is taking care of language skills for the students. I'm raising this point also because when I'm learning at institutions of higher education, much of the literature is in English, and my comprehension skills are not toned to that level. So I feel neglected. I'm not able to do my assignments. I'm not able to take part in the classroom discussions. And therefore, what should I say? Maybe the trauma, the discontent, inability to be able to perform well enough in my classroom, again, puts me in a kind of thing where I could also be facing the kind of aggression by way of not only my colleagues, but also my teacher, right? So, and a lot of the time as teachers, we've also posed to be the well-wisher and the mentor, and therefore advised you to leave the course and go away because you can't cope up with it. This is where my problem begins. As a teacher, perhaps my role is to hone your skills as a student, and therefore all measures that I may be able to take as a student, I should be doing that. So to me, I think one, at this level, the linguistic or language skill development, and in doing so, perhaps some kind of care and counseling which could be given to me by way of overcoming this inhibition of language, and therefore not being able to dispense in the classroom the way I am expected to do it, right? So these are 2 points which are coming to my mind as I probably talk to you in this. And maybe the research is another element, the whole realm of research around these lines, are some of these questions being raised by way of addressing these, disparities, if I may say, in learning across the thing. So when you kind of want me to talk about where did I experience this, I think there are realms of these kind of aggressions coming in from the teachers as well as the colleagues. Another example that I could give you is very, very, very recent. One of the students who's joined the program and has not attended any of the classes. Right. The idea is to therefore report that so-and-so has not been attending the classes, and the university can take a call on that. That's my job as a teacher. I am not too happy when I recommend that her name should be struck off the rolls. That's not my job as the teacher. That's the job of the university to take a call. So this is, to my understanding and my, I mean, I would want to argue it as a microaggression because this individual comes from a particular kind of background. Had the same student be of a different background, which is perhaps the privileged background, I'm not too sure if the reaction would have been similar or reaction would have been same. And within that, when you're talking about microaggression, let me bring in this realm of disciplinary microaggression, if I may use this word. Like I said, I am in a center wherein we have medical professionals and social scientists of different streams, right? Both as students and as colleagues. But there is a very neat divide in terms of those of us who are coming from the medical backgrounds and those of us who are coming from the social science background. Within that, the other element which is happening is among the medical, backgrounds also. It's the allopathic background, which is right here versus the other backgrounds. And then even within the allopathy, it's the doctors versus nurses. So I mean, you can imagine the layers that are there in terms of the kind of hierarchization that we do in our own profession. And similarly, perhaps from in this realm of social sciences, the economics versus the social work right here at the bottom, although we are telling each other, we are telling ourselves that public health is a field wherein we take call from interdisciplinary perspective, and therefore no discipline can be higher or low. But then you get to hear this every second day, to the extent that medical fraternity does make you feel as a social scientist that medical fraternity is higher up here and the social science fraternity is lower up here. And this is including my own personal reflection that I've experienced over 20 odd years of being here in the center. Right? So, and I'm quite open about it, and I've tabled it also many a times. Senior colleagues who have been, making very special efforts to bring public health in the domain where it should be, in that biopsychosocial framework, being an activist too, in order to bring this framework work, also kind of make that demarcation, public health versus social sciences, right? So that's the point I'm trying to make here when it comes to.
Totally. I think it makes a great deal of sense, Dr. Acharya, that there are hierarchies, even within our own disciplines and within our own careers, and our different places of employment that do create this compare and contrast sort of dichotomies that really, if one were to look very carefully at, in itself is a social justice issue, right? If you have this organizational hierarchy in the place that is supposed to serve everyone through a non-hierarchical, non-inequitable, through the lens of more of an equity and inclusive and everyone being at the same level, it kind of makes you wonder, because the contradiction is it's so direct. It's right in your, right in front of you, whether it's you as a person who works for that place, or if you're a person coming into that space getting service. It seems like there are hierarchies both within the service and hierarchies both within the place of employment and the institution. So I think you make a very strong point when you think about disciplinary microaggressions, but it sounds like you've also made a point about structural levels of discriminations through these hierarchical organizational formats that exist. So that's a very interesting way to think about it as well. So thank you for that. Now with all of these, issues around discrimination and microaggressions, I wonder if we can, start thinking a little bit about question 5, which is more about where do you turn for inspiration or support when dealing with structural and policy inequities, if any, that you face in your field that we've been speaking about.
Yes, thanks, Manu. I think my first, discomfort with this kind of microaggression was it took me a while before I could actually, imbibe it and share across. And then most of the time, you do tend to fall back on your teachers. And it so happens that I'm teaching in a university where I've learned to. Uh, so I could fall back on some of my teachers in terms of getting a sense of why is this happening. And I'm sure it happens across disciplines too. So, and I feel a lot, I feel indebted to my teachers, especially to begin with my PhD supervisor, Professor Nangia, who taught me what population geography is. How do I place my arguments in the realm of population geography, which is where I kind of learned how geography as a subject can actually be spilled over to questioning the associations, the discourse on population and development, which also brought me in a conversation with yet another teacher of mine who today is recognized as a very important, he is an economist by training and is recognized as a very important voice in the literature on discrimination and exclusion. And I'm referring to Professor Sukadev Thorat. You may be familiar with his work by way of, a literature, a huge literature that is generated. The vantage point, of course, being the economic realms of discrimination to coming down to how they spill over to other realms. And like I said, as a teacher, in fact, he not so much directly in initial years, but subsequently when I got a chance to work with him as a director of Indian Institute of Dalit Studies, it gave me a lot of insights in terms of not only understanding the nuances of explaining how we understand microaggression by way of discrimination and exclusion, marginalization, and perhaps deprivation, but also theorizing it in certain ways, conceptualizing it in certain ways, because to me, I think as an academic, that was very important to be able to make it measurable in some way or the other. So I think I can say that his work was a mighty, contribution. It's considered as a huge contribution. And for the likes of us, it was the process of learning. The other person that I might want to bring on board also is somebody who has written on the realms of discrimination in the field of education in India. And this is Professor R.K. Kale, who happened to be the Vice Chancellor of Central University of Gujarat. Being a life scientist, I thought his understanding or his reflections on the idea of discrimination largely, in fact, come out as we converse once in a while, are by way of his sitting through the interviews, etc., as member of the committees, etc., at various institutions, various time points, that he kind of feels that however much policies have made us, conscious about the thing, subconsciously, perhaps these elements are still visible and making a dent into our lives. One more person I think I will want to talk about is somebody whom I'm related to. And he happens to be an uncle of mine and a very strong Ambedkarite. Uh, he has been awarded honorary doctorate by many universities, and he's named as Dr. Bhagwan Das. In fact, why I said he's related to me, sorry, I know it's time for us to wind up, but it's so exciting that you've been making me speak. This gentleman is one person in our clan, our extended clan, who's had an opportunity to work with Dr. Ambedkar for a fairly long time. In fact, he did a lot of writing for him, especially when Dr. Ambedkar was unwell and he could not write, he was the one doing that part for him and often raising questions also. So as children, as kids in the family, we would be listening to the stories of how the elements of discrimination, we may not have understood then, but we could figure out, okay, something which is not right is happening. He would tell us things about that. He would tell us how the Burakumens in Japan are facing the elements of the First Nations in Canada. In fact, the First Nation I heard from him for the first time. It's only subsequently that I read and understood what are the issues of First Nations, etc. So the point, like, and he's written good number of books alluding to this. In fact, one of his books is talking about Ambedkar's own philosophy of social justice. Thus spoke Ambedkar. That's the title of the book, which perhaps is no more in publication, but I'm sure there are some people who have procured it. Now Navian has procured it. So if you ask me, I think these are the three people who have really influenced me in developing my understanding of the question of what we are now talking in terms of microaggression. And perhaps that's how I have also managed to react to the experiences that I could have had in many different ways. First time when I experienced, I know I'm lengthening it, I was appearing in the interview for my master's program at the university that I'm teaching at the moment. And there was somebody, yet another candidate who was there. And she asked my name and what is my religion? And by religion, I'm a Buddhist. So I said, I follow Buddhism. And then the second thing she told me, oh, then you don't have to be worried about admissions. You will get admission. You have reservation and all. I said, hold on. Just because I'm a Buddhist doesn't mean that I am using reservation. Please remember, there are many of us who do not use reservation for the simple reason that if I am economically, I have that parity to, take care of the expenses. If I give up, somebody else who's more needy will be able to make use of that. And that's what I learned from my father, my parents, to be precise, right? So that's the first microaggression which I experienced live, first time when I come out from my, domestic realms. So I thought I must share this with you.
Well, thank you so much for sharing that. So just two technical questions, okay? Just to follow up. One, when you speak about reservation in this context, does it mean that you get a subsidized fee? Is that what that gives?
Very much.
Okay.
Very much.
All right. Just for all of our listeners who might not have that context. The other piece you spoke quite a lot about was the economic discrimination. You've spoken about it multiple times in our podcast today. And I just I wonder, does India's constitution talk about equality across socioeconomic status? Does it actually speak that you cannot be discriminatory towards those who are financially poor? It does? Because in Canada, we don't have provisions when it comes to the social class based on your economic class. Like, it's not within our charter. We don't have that.
If I recall my constitution correctly, going by Article 15, while it says the emphasis is on social identity, you cannot be discriminated on any axis.
Right.
I can probably share this out with you. This is one of the articles. There are many other. I'll have to probably go back and pull them out also for my own this thing. Economic parity that's where perhaps the whole idea of OBC reservation has been brought in place, right? But if you
what does OBC stand for?
Sorry, I'm coming there. OBC, see, the realm of reservation was really not for economic reasons.
Okay.
Right? The reason for proposing reservation was that despite economic parities, quote unquote, your social identity matters and you can be discriminated based on gender, your caste, your religion, etc. right? So the idea was that do we make sure that I'm not the people of the country will not be discriminated on that, because uh, the idea of economic parity was not really taking care of my discrimination based on other identities, right? And therefore the move to bring in economic parity, and that's where you see a lot of literature which emanates in terms of poor and non-poor, to be able to pose that even among those of us who are socially at a higher ladder may still be poor, and therefore the need for reservation by way of the economic parity. And that's where the OBC, which is other backward classes, some of the states, provinces, which is for you, have something which is further disaggregated as those of us who are very, very marginalized, right? So there's yet another category over and above this. So EBC, economically backward classes, okay, economically weaker section. So you do have the affirmative actions based on the economic parity also, right? Economic criteria also. And I can give you more details, maybe share with you otherwise also. But then the marker was that the intention to be able to bring in social realms wherein you recognize me by way of my attribute, which is social, which is inherited, therefore by way of acknowledging that there is no, you can't really, just because you are at a higher echelon of social ladder, you can't discriminate me at the lower level. The nuance being that much of those who are at the lower level of the social ladder are also economically poor, or economically at the lower ladder. That was the nuance, and that's how the realms of the other reservations, there've been huge movements and campaigns for reservation for this other backward classes also. And some have, in fact, we already have in place reservation for EWS category in employment and in education.
Okay, thank you very, very much for clarifying both of those questions of mine, Dr. Acharya. It's very helpful and very, it helps contextualize the conversation for those listeners who don't have that experience in India and understanding. So that's very helpful. So we are going to come to our last question, if that's okay. Question 6 is, what are some possibilities or recommendations that you have to help promote social justice education in your discipline?
Okay, maybe I'll try to maybe call out from what we've been talking about all this while. And what comes to my mind first is the very idea of empowering the language part of it. We might want to call it linguistic empowerment or language skills, or whatever phrase you think is more appropriate. And I emphasize on that because it does bring in that feeling of empowerment. If I'm able to converse with you, suppose I was not able to talk to you in English, I know I would have felt embarrassed. I would have felt sorry that I'm not able to communicate with you, etc., etc. You may have tried to help me out, but not everybody may have done that, would have done that, right? So I think linguistic empowerment or language skills, whatever would you want to say, is probably the way, something that I would think should be put in place. Similarly, perhaps a unit in institutions, particularly educational institutions, wherein as a person who is facing the problem of, let's say, uh, loneliness by way of language, by way of social identity, by way of economic crises, can I, go and converse in that cell, which could be a composition of, let's say, teachers, students, non-teaching units, and similarly, maybe at workspaces also, a similar kind of entity could be evolved, And also perhaps since we already have some of these entities in place, we already have gender sensitization cell, ICC is what we call, internal internal complaints committee, right, which is largely for sexual harassment, etc. We have boardings in the hoarding which are put in the educational institution that ragging is punishable offense. Similarly, perhaps something to the tune of sensitizing people across gender, across social identities can also be put in. Even for ICC, I see the wording being put in most institutions now. So why can't we do the same thing for other disabilities, quote unquote, that we experience and want to overcome? The other element, and as an academic, I think I would fall back on the research part of it, creating that enabling environment which gives us the leeway of researching some of these, addressing some of these research questions, both within the country and drawing lessons from across the countries. Meaning to say, this, if you're saying that microaggressions are across everywhere, why can't we learn lessons from each other? So maybe some kind of research environment that we could create, we could generate, could be one way to take note of it. Grassroots level workers perhaps becomes yet another element, yet another point to raise over here. Like I said, drawing from my own study, we see this kind of disparate behavior more visible at the grassroots level workers. So maybe that's the time, that's the place, that's where we want to enforce energies, not overlooking their extra burden that they have, the points that they are interacting with people on an everyday basis. That itself has its own kind of crisis. So I guess we need to probably look at that set of realm also. And maybe if I say in terms of the programmatic realms, reiterating the fact that we already have a strong affirmative action policy, we have good number of programs embedded within that policy. Translation of that policy with empathy and with perhaps group-specific intentions and group-specific targets, perhaps is not a very good word, but group-specific orientations maybe is a good way to see a different kind of result that we might want to experience by way of getting these policy recommendations or policy regimes in place. So that's what comes to my mind.
Oh, that's wonderful. You've really thought about it from multiple different angles. I mean, you've gone from the personal to the personal / practical to the more organizational, the more long-term and short-term ideas. So Dr. Acharya, thank you very much for creating, so many different possibilities for us to think about. You've named 5 really big ones. So I really appreciate you taking the time for, sharing these recommendations. And I'm sure that our listeners will think very deeply about these possibilities and these recommendations and see how they actually would cut across multiple different disciplines from the different, podcast participants that we bring onto this platform. It's always nice to hear some similarities when it comes to possibilities and recommendations to move forward. So I really, truly enjoyed having this conversation with you and all your nice insights on all the things that we can do. I think you've given us a lot to think about today and a lot to hope for tomorrow and future generations to do this great work that you have, started and inspired us to continue. But so, I really thank you for all that. Do you have any final words or comments before we close for the day?
I think as a final set of words, Manu and Juliana, I would say that a lot rests on your shoulders as young scholars who are getting into this realm. And I see this with a lot of responsibility also. That's where perhaps the role of our generation comes in. Are we in a position to, enable you to imbibe what is needed to understand social justice and to be able to execute social justice by way of perhaps the vision that Ambedkar had
Right.
and gave it to the Constitution, right? And we are all governed by the Constitution. So if we can do our bit to be able to bring that on board, I think half our job is done. Everything else is likely to fall in place.
It's
That's
very
where
inspiring words there. And we do hear the responsibility. It is a heavy one, but we do think that it's a very important one. So I think all the listeners and all those people who are taking up social justice work in all different disciplines, including healthcare, will heed to your calling of action from us. So thank you so very much again, Dr. Acharya, for being with us today. And I look forward to hearing what we come up with across all of the different interviews and sharing that with you.
Thank you. Thank you so much. Thank you both of you, Juliana and Manu. Thanks a lot. Lovely talking to both of you. And I have learned a lot too. Thank you. Thank you so much.